All right, welcome back from the break, everyone. Thanks for tuning back in. The last subcommittee that we have a presentation from and recommendations is going to be risk reduction. Unfortunately, Joanne Pike couldn't join us today, but we are going to continue with the agenda and move forward. We're pleased today to have Heather Snyder from the Alzheimer Association present late-breaking findings from AAIC in regards to risk reduction. And then Rhonda Williams is going to present the risk reduction subcommittee's recommendations. So Heather, over to you.
Great. Well, thank you very much. And it's an absolute pleasure to be here with all of you and see a number of people that I sit with or have joined in other meetings throughout the year in person and have an opportunity to share with you some of what came out of AAIC in terms of the risk reduction. And we were talking a little bit before, and I think Dr. Libre shared the challenge in having a short amount of time to cover an immense amount of information that we're constantly seeing with new results, new studies that are being produced. So I really condensed this very specifically to some of the updates that came out of AAIC last week or over the last week and a half and some of the learnings and discussion points. But of course, if you look just in the last 6 months, there have been a number of studies that have looked at things like the relationship with obesity, with hearing loss, and with many other associated risk factors and dementia. So while the slides are coming up, just to start, and I think we've heard throughout the day, last week was the Alzheimer's Association's International Conference on Risk Reduction, the International Conference, and this is really the world's largest meeting in Alzheimer's disease. Just a question, these slides are different from those slides. Do I advance here? Perfect. All right, so if you look at AAIC, this is the world's largest convening for Alzheimer's and all dementia science. So we had a little over 5,400 scientific presentations and a little over 14,000 participants that were joining from all around the world, including 8,500 that came together in Philadelphia last week. So there's the conference, the main conference, but then there's the pre-meetings and the pre-meetings as well. And this really covers the entire spectrum of disease, and we've seen a number of presentations that have referred to this, whether it be the biological underpinnings, whether it be some of the things in recruitment science and care services, the clinical trials pipeline and the need to increase diversification in the pipeline and some of the work that we're understanding from trials going forward, the growing understanding of health disparities and how to address those, treatment updates, and you heard a little bit of that from Dr. Libre, the diagnosis and staging criteria across neurodegenerative diseases, advances in tools and detections, and so much more. But of course, we also saw a number of studies that really looked at some of the related risk factors that we see in dementia for all of the diseases that cause dementia. So we really started the week with a pre-meeting that we from the Bold Center that really brought together a number of experts to talk about how do we actually impact behavior change. So as we understand more and more about these risk factors, about what may increase a person's risk or decrease a person's risk, how do we then influence behavior change? So, you can take lessons from cardiovascular health, for instance, where it's, these sorts of behaviors are going to be able to benefit you in terms of reduction of a stroke or a heart attack. But actually at a community level, implementation of some of those factors, that's a challenge, and there is a lot of behaviors that need to then be incorporated. And the example that was really discussed quite broadly throughout this workshop was looking at smoking cessation, and some of the behaviors that needed to be modified more broadly in looking at smoking and smoking cessation. And so this workshop was really specific for public health individuals and public health experts to come together to talk not only about what's that landscape of risk and what do we understand about those behaviors, but actually how do we then think about behavior change and start to think about incorporating that behavior change into the broader spectrum of the work that we do more broadly. But then as we went into the meeting, probably the largest story that we saw throughout the week that was around risk reduction was the Lancet Commission report on dementia. And this was first presented in 2017, again in 2020, and then this is the updated report in 2024. And what they suggest is that there are 14 risk factors that, if modified, would be able to reduce dementia prevalence by about 45% globally. Now, there's some assumptions with this estimate, including that all of these risk factors are in fact causal and that they can be completely eliminated. So it's important to take that into consideration, and I'll talk about a commentary that was also came out at the same time in just a moment. Now, when they look at these 14 risk factors, this is actually 2 additional risk factors from, or 2 modifiable factors since the 2020, and that's specifically looking at high HDL and vision, and those were the 2 that were added in. So and one thing just to note, and this really builds off of what Dr. Libre mentioned earlier, is that this is putting out that this is across the life course. So as we understand what may be contributing to the brain changes that we see in these diseases that cause dementia, they actually are really throughout the life course, and there's a number of different things that may influence both increasing and decreasing a person's risk throughout that life course. So starting really in the late life, and this is where the one of the risk factors was added, one of the modifiable risk factors was added in this new report, really specific to vision loss. Now these sensory, the sensory losses or the sensory impairment, such as vision and hearing, are 2 that we've seen really an increased attention around in recent years. We've certainly seen a number of studies, being more increased studies at AIC. Last year, for instance, we heard the team from Hopkins that reported out on the ACHIEVE trial, which was looking at a hearing intervention. And while the overall trial was negative, what they did see is in a subset of individuals that had increased cardiovascular risk factors, they saw a benefit. So really suggesting that you might have some synergy between these risk factors and you may see an increased impact on an intervention with those factors. So certainly more research needs to be done in that population that may most benefit. But when we look at vision loss, there's a number of factors, and I heard some of the discussion earlier today when we were walking to lunch was around, well, when you think about cognition and testing cognition, can you visualize, can you see the pictures that are being used, or some of the types of cognitive assessments? And that's certainly an issue that we know is part of assessing an individual's cognition. There hasn't been much work that's looked at vision interventions to understand if you're able to modify and if that has a benefit. But you could also then think about things like if you have poor vision, you may not drive as much, you may not go out as much, you may have decreased social interaction, you may not participate in some of the same cognitive activities or cognitive stimulation activities that you would if you did not have vision impairment. And so it's questions like that that really are where some of the additional research needs to happen going forward. But we also saw a number of things looking at some of the late life risk factors around the environment. And one of the big stories that we saw come out last week was around wildfires. And this is really one of the first times that we've seen a study that looks very specifically at exposure to wildfire smoke and risk of dementia, suggesting that there is this increased risk for individuals that have had exposure to wildfires. And so really looking at this as a 10-year study of individuals from the state of California with this increased wildfire smoke exposure, and actually specifically that when they look at a particular type of particulate matter that is present in wildfire smoke compared to just general air pollution, that's actually what suggests maybe the impacting an individual's risk. And so when we think about trying to understand, again, across the life course, this becomes incredibly important to think about what might be that cumulative exposure an individual has of a number of different factors, and perhaps wildfire smoke is one of those. So now moving in and bringing, kind of centering this on the Lancet Commission report, looking at midlife, you can see there's a number of different factors here that were identified in both the 2017, 2020, and now in 2024, with the newest being added as the high LDL cholesterol as being one of those new modifiable risk factors that was identified in this commentary. Now, while that data has been more about association and there's really been less cause and effect data that has come out, there is quite a bit that's in the overall cardiovascular health and the linkage between cardiovascular health and risk for an individual, including interventions that have looked at, can you modify blood pressure, for instance? And I think one of the earlier studies talked about the reduction of blood pressure as being one of the strategies and one of the educational components for clinicians that I believe in the federal updates we heard a little bit about. And in fact, one of the studies that we saw report out at AAIC this year was the continuation of Sprint Mind. So for those that may remember or may not, Sprint was a cardiovascular study that was looking at aggressive reduction of systolic blood pressure below standard of care. over a period of time. It was so successful, actually the study was stopped because it met its outcomes very early, but there was an ad hoc study or an add-on study called Sprint Mind that was continuing to track individuals and measure the impact of the intervention on their cognition over a period of time. Now, this study actually first reported out in 2018 at the Alzheimer's Association's International Conference and subsequently published their results, where they saw a 2.5 times reduced risk of mild cognitive impairment and dementia in individuals that had the aggressive treatment versus those that did not. Now, at that time, they actually then continued forward with following up those individuals for a longer period of time, initially with funding from the Alzheimer's Association, with additional funding that came in to expand and continue that study from the National Institutes of Health. And what you can see is that they actually, starting in 2018, they re-engaged the participants and then continued to follow them over that 5-year period of time. Of those that were eligible, there were over 7,000 people that were eligible for continued follow-up, and they were able to assess the cognitive status on a little over 4,000 of those individuals. Now, this is under review right now, but the main takeaway of this study is that among the ambulatory events, adults with hypertension and elevated cardiovascular risk, with that 3.5 years of treatment, that was the duration of the original study, down to the 120 versus what was standard of care. They actually continued to see a statistically significant benefit for those individuals that had the aggressive treatment for mild cognitive impairment and mild cognitive impairment or probable dementia. Now, they didn't see that for probable dementia alone. And there's definitely some questions. The study wasn't necessarily set up as a dementia study or as a study to assess cognition, so there wasn't ascertainment at the very beginning of the study for an individual's cognitive assessment. But it does suggest that as we think about the bigger picture of risk reduction, that effective management of blood pressure is one of those strategies that should go forward. And it was great to hear in the federal updates that a number of the risk reduction and prevention webinars and educational programs for clinicians are including this as part of that messaging and part of that strategy. And this study further confirms that. Now, in looking at the Lancet Commission, there was also a commentary that accompanied this, and this gets to the bigger picture that I mentioned. So this does make a number of assumptions, or the Commission report does make a number of assumptions, including that it estimates that these risk factors and that these risk factors are causal for these individuals and that they can in fact be eliminated. The idea of the multi-domain, so that synergy that we talked a little bit about, that's not necessarily taken into account in the Commission report. And when you think about what may actually be able to be beneficial or be able to see the impact of reduction of those modifiable risk factors, really thinking about the investment in multi-domain trials, and I'll talk about that in a moment. One thing that's not included in the Lancet Commission is diet, and we continuously see, and in fact, if you look over the last 12 months, there's a number of report outs that have looked at different diets and components of diets that have been shown to be either associated with an increased or a decreased risk for individuals associated with dementia, and that's not something that was included in the Commission report. It is complex, especially when you think about diet, nutrition, dietary patterns may tie to the underlying immune response of an individual or the immune activity of an individual. That may tie to the gut health, and that may tie to the brain health, and it's all interconnected as well across the board. And of course, this really is a key takeaway, is that there is this need to really have these multi-domain trials that will allow us to think about and understand that synergy in populations. It's not going to be a one-size-fits-all. And in fact, thinking about some of the data that comes out of diet, one of the studies that we did see that we saw a lot of headlines around as well was on the link with processed red meat, and we've seen this before when we've looked at ultra-processed foods overall, but this was very specific to looking at red meat, and this actually pulled from individuals that were healthcare professionals, both nurses and clinicians, over a period of time that had an average follow-up of 43 years. And what they suggested is that eating about 2 servings per week of processed red meat increases a person's risk of dementia compared to less than 1 serving per week of red meat. and that they actually looked, and when they did some modeling, that if you replace at least one serving, you're able to modify that risk in some context. But of course, that's modeling and not necessarily an intervention more broadly. This did include over 130,000 individuals that had been followed for 43 years, so just the robustness in terms of the study going forward. But it gets to that message that diet and the linkages of diet is really important when we think about modifiable risk factors. Now, thinking about some of the multinational intervention studies, this is a picture that during AAIC from the Worldwide Fingers Network meeting, where we actually had representatives from about 60 countries that convened. This is those who were in the room, but there was also about another 100, I think, or so that joined virtually, really to talk about some of where these studies were, share learnings. I think the topic in this last meeting was really around recruitment and retention in these kinds of studies as we go forward, and thinking about how do you engage the population. Many of these studies are with individuals that are thought to be at an increased risk, but some are with individuals that have mild cognitive impairment as well. And so thinking through those recruitment and retention strategies as we're looking, again, it's not going to be a one-size-fits-all. And so how do we ensure that we have some synergy and harmonization across these studies so we can really look at what are the aspects of the intervention that are beneficial to the folks. And then we had a panel that talked through 6 of the different studies, reporting out different aspects, including the cost effectiveness of these types of interventions and what that may mean for an individual or for implementation of these interventions, looking at some of the baseline data as these studies in some cases are fully recruited. You heard a reference earlier to US Pointer, which is the US-based study of a little over 2,111 people to be exact, that are randomized into 2 interventions, self-guided and structured, ongoing right now. That study is expected to report out at AAIC in 2025. So we are on an aggressive timeline as we finish out that study to really try to understand what that multimodal intervention is, what the impact may be on cognition over the 2 years. Part of US Pointer has actually been an incredible investment from the National Institute on Aging, adding in imaging, microbiome, vascular measurements, and sleep measurements as well. So just the wealth of data that's coming out of that study, not even just the outcomes of the study, but out of that study with the robustness and diversity of the participants with that type of assessment, and all of that data is being shared broadly with the scientific community. Now, just to end, I think one of the things is we talk about when we're talking about risk reduction, or all of the areas of risk reduction and the science that's going forward, we're continuing to see all of that move forward. But we heard from Dr. Libre earlier about these diagnostic tools and that work, and some of the work on treatments more broadly. And some of this comes into that landscape of how do we define a disease. And when we think about these diseases that cause cognitive impairment in individuals, how do we define the disease more broadly? And pulling from the example of cardiovascular disease, in the final day's plenary by Dr. Risa Sperling highlighted this, and that when we look at the WHO's definition of cardiovascular symptoms and more broadly, it talks about that there are not necessarily symptoms, that you don't necessarily, there are often no symptoms that an individual may initially experience, suggesting that the underlying biology may be a component, that is a component of the disease. And that when you actually drill down, you can think about that most cardiovascular diseases can be prevented by addressing some of these factors. And so if we think about that model in the diseases that cause cognitive impairment, the idea of risk reduction, the idea of potential prevention of those factors more broadly may be a multimodal approach, may be a singular approach, may depend on the individual, but really is looking across the entire life course as we understand how all of these pieces fit into that bigger puzzle, and really addressing how do we address that underlying nature of the disease so we can stop or slow that progression throughout the entire continuum. And so thank you very much for your time and your attention. One thing I did want to note just is that as a new component this year at AAIC was something called AAIC for All. This was a free event that really took a lot of the highlights throughout the week and synthesized it at the very end, one for the general public and one for clinical professionals, as an opportunity of how do we bring the science more broadly. And I think, again, this gets to some of the messaging in the federal updates of the importance of sharing and communicating all of the incredible work that's going on more broadly with all of our communities across the board. So thank you very much, and save the date.
Okay, I've asked Heather to stay at the podium. Do we have questions in the room or online? Stop sharing. Rhonda, floor is yours.
This has been excellent today. Thank you. I just wanted to ask you, Heather, in terms of your time at AAIC and the presentations you were in, any guidance or things you really want to point public health toward to paying attention to? I think certainly we are with blood pressure, certainly with smoking cessation, but any other factors that you think, even in a year's time, that we can give more consideration and weight to in our programming? Thank you.
Yeah, no, that's a really fantastic question. And I think in, looking at it, the multi-component interventions and the idea of how do we integrate some of those aspects into the different public health strategies is certainly a key component, and understanding and hearing a little bit more about what those different interventions were. So that was I think that particular session and reporting that out is important, and we'll see some of those trials then report out their results in the next year or so. The other is, as I mentioned, the Sprint Mind and that linkage and that association and that understanding of the bigger context across the what may be that longer term follow-up and impact more broadly, but also a recognition that that's a piece of the bigger puzzle that's out there. There was a number of sessions and presentations that really looked at the community engagement and community-based engagement as well. And so when we think about how we're communicating or talking about the diseases that cause cognitive impairment more broadly, thinking about those strategies in our conversations, whether it's we're talking about recruiting for a study or we're talking about public health interventions, is another place that there's a lot of crosstalk and should be a lot more crosstalk among our spaces.
And Jolie.
Hey, Heather, thanks so much for the great presentation. I was at AAIC last week and simultaneously excited and very overwhelmed with all the great stuff happening. So today's presentations have been really helpful. I'm kind of curious from your perspective, and it's a little bit reflection on AAIC and sort of where we are with things. I think the WHO reference to defining the disease and the example of cardiovascular disease is actually really important. And a question that I've kind of been asking myself and others all along is, we've been investing for many years, decades really, in cardiovascular health and on a lot of these same risk factors. Like I had a heart health, graphic that I shared before. What do you think is different? Is it just the multi-domain intervention, or kind of what's different now in the science, and then maybe sort of forecasting and moving forward? How do we sustain and implement these big multi-domain interventions? Because my read is they're pretty complex. And so a little bit of reflection and then maybe a little bit of crystal ball for you would be appreciated.
Yeah, I'm just going to make sure I understood your first question, because I was having a little bit of a hard time hearing, and so apologies for that. Was really looking at what's different about the science in thinking about these interventions for cognitive health versus heart health. Is that? And then the second is then the sustainability around the implemented interventions, should they be successful. So for the first one, I think there's some is that it's not different, and some is that it is. I think in terms of some of it is the conversation that we have around these diseases and what that may impact an individual, and so I think raising that awareness and having then that impetus for action is a little bit different. The other side of it is that there and this was where, for me, that workshop, the pre-meeting, was really quite interesting, as we think about some of the social messaging that we have in the communities and think about how to impact that more broadly. And that was the example that they gave really to smoking cessation and some of those linkages around, the types of warnings and the types of labeling and the types, some of those considerations. The ability, or as we think about the interventions or whatever those interventions may be, or the different public health strategies may be, what can we bring forward from those lessons, and what can we then bring forward for implementation in a sustainable way, which I think is a little bit what your second question is getting to. The other part of it is that these interventions do add in more of some of the cognitive assessments and cognitive engagement aspect as well, and some of that team approach. to engaging the individual. And so I think it's that recognition, and this gets into the science of how do you make behavior change, and that recognition that some of these, and for many people, behavior change is very difficult, and you need the type of social supports, and how do we then think about those social supports, and where can we pull from examples where we've been very successful in bringing those forward and ensuring that that is present within the communities at large, more broadly. And that gets a little bit to the sustainability component. So as we think about this, as we think about as the outcomes of these studies go forward and we translate those into public health strategies, that's really a part of where, at least in the Alzheimer's Association, we're so incredibly appreciative of the partnership that we have with public health communities, with you all, with so many others, that there is a path for implementation out into the community and a path going forward with that type of implementation. The sustainability in terms of the structures and some of those components that come into place, I think is a bigger conversation than probably right now, but it is there, and the roadmap to being able to do that is also something that I think when we designed US Pointer, we were very intentional about what that kind of translation would be, and that's part of why the intervention is being done in the community and not in a medical center or somewhere else, so that translation into the community is already ready-made and really builds on partnerships and bridges those partnerships and those community leaders in a meaningful way.
Hi, I just want to make a follow-up comment from the aspect of primary care. And when we talk about that, it's a big overlap with cardiovascular prevention, and we've been working at that for a good 10 years or so, and the audiences for those have been receptive to as much as they have been. But now when we're talking about that these are risk factors for dementia, it's a whole nother audience, especially those caregivers or younger people who are seeing their parents and wondering, what can I do? And they want to know what they can do. So it's a real good message to be able to say, it is something you can do. And it's been very encouraging and exciting to be able to bring that forth. Yes, it's the similar type of intervention, but the audience is a little bit different, and they're more receptive because they're able to see what, if you don't do it, what can happen. Thank you.
That's a great point. Important point. Okay.
I have perhaps an uninformed question. So if hearing and vision are major, relatively major risk factors for dementia and Alzheimer's, then what is being done in terms of providing that for the population? My personal experience is it's challenging sometimes to get that covered by standard insurance companies. And so given that hearing aids are expensive, do we know what, are there any efforts either research-wise or health implementation-wise for hearing and vision?
I can maybe start with the research-wise, and that at this point, most of the research has really been association, and so not necessarily a cause and effect, and it's been less clear on that cause and effect component. But when we think about healthy brain aging, the importance of vision and hearing is certainly part of that conversation. And I can at least, the other side that we've done is then we've really looked at how can we translate that to some of the messaging and some of the components of the guidance we'll give to an individual that may be going and having that conversation with their doctor is ask about your vision, ask about your hearing, and that's part of it. And separately, the Bold Center for Early Detection, I think, has within their manual that they provide to primary care, has a wealth of information that's in there that includes assessments on vision and hearing as part of the recommendations for the healthcare professional to incorporate more broadly. So that's not a complete answer to you, but I think we are starting to build that messaging in both from the provider side as well as from the patient and the community side. Someone else might be able to address the coverage component.
Yeah, I would like to hear more about the coverage component, but in terms of research and causality versus association, at least recent reports, randomized clinical trial on correction of hearing having a demonstrated effect in a population at high risk for cognitive decline in Alzheimer's and having a significant effect. So always room for more and larger, more diverse populations, but a randomized clinical trial demonstrating effectiveness there, not yet that I'm aware of for vision correction.
No, not yet. All right.
I can add, thanks to Google, that House Bill 33 would add dental, vision, and hearing benefits to Medicare. So legislation has been introduced in the House and the Senate. I'm scrolling. But they have not passed either house. So there's legislation on the Hill, but have not moved forward.
Can you scroll dental too?
Yes, it says dental as well. Yes.
Okay. All right. Thank
All
you.
right. Oh, thank you so much, Heather. Join me in thanking Heather, please. We have sidebar about dental health here. Next, if she is up for it, I'm going to turn it over to Rhonda to lead us through the risk reduction subcommittee recommendations. I can share screen, Rhonda. She's frozen. All right, we'll give her a second. Talk amongst yourselves. There she goes. Now you're moving, Rhonda.
Helen, the audio is really, I'm sorry, I'm going in and
Rhonda, you are, gone. Oh, there she is. Rhonda, do you want to try turning off your camera to see if that helps with your bandwidth? Yep. We're just going to read them. May I do it? Let's give Rhonda a second to rejoin, and then we'll pivot if we need to. This is our cognitive flexibility. I hate silence. While we're waiting, we can share that our next meeting is Monday, October 21st. So if you don't already have that on your calendar, please put it on your calendar. And it will be in room 800, which is good or bad, depending. Let me know. Let me know. Okay, Rhonda is caught in a storm. She's got a huge downpour. So we'll start with risk reduction recommendations. I'm happy to walk through them, and if anyone else who's on the subcommittee would like to chime in to add color or more information than what I'm going to review from the slides, please do. And if Rhonda can join us, we will pivot over to her. So again, thanks for your flexibility. Ugh. All right, so the risk reduction subcommittee has been meeting monthly. There are very few non-federal members, so this is also a call to our non-federal members. If you're interested in joining that subcommittee, I'm sure that they would love to have you join. Many feds do join that group, but I think it would also benefit from more non-federal members to provide input on that work. One second. So the first recommendation is to identify priorities and track progress towards addressing cognitive decline and dementia risk factors across the lifespan. Like other subcommittees, the subcommittee is recommending that Congress should reauthorize and provide appropriations for the NAPA work broadly. And then recognizing that there are many, 14 now, risk factors for dementia, thinking about prioritizing those risk factors to focus on. And so the subcommittee recommends focusing on six risk factors: midlife hypertension and obesity, physical activity, smoking, depression, and hearing loss. HHS should track the prevalence of these priority risk factors by race and ethnicity, education, income, and among those with neuroatypical conditions, and as well as the efforts to address these risk factors. HHS should establish a monitoring and evaluation work group no later than May 2025 to recommend specific indicators and data sources to be used, consistent with the infrastructure for the Healthy People 2030 activities and the Healthy Brain Initiative roadmap. And then no later than 2028, HHS should convene a second AD/ADRD Risk Reduction Summit with CDC as the lead agency. In addition, HHS and all federal agencies should build upon existing risk reduction activities for cognitive decline and dementia and identify, coordinate, and implement additional strategies on priority risk factors identified under Goal 6. HHS and federal agencies should expand reach by partnering with non-governmental organizations currently working on risk factors for cognitive decline and dementia and synergize their work and that of the agency. In addition to annually reporting on activities undertaken towards Goal 6, federal agencies should annually report on significant actions and progress at the state, local, and tribal levels and identify gaps that need to be addressed. HHS should issue a public report on current federal and state level spending on activities addressing cognitive decline and dementia risk factors. Each year in the annual administration budget, the Office of Management and Budget should identify the amounts proposed in the budget request for addressing cognitive decline and dementia risk factors across federal agencies. And then not less than every 5 years, HHS should update the list of priority risk factors of focus to achieve Goal 6 of the national plan. Recommendation 2, accelerate public health and aging network action on addressing the risk factors with the strongest evidence of beneficial impact on dementia prevalence, particularly for communities or groups at greatest risk. So the federal government should sustain and strengthen public health and aging network infrastructure to address risk factors for cognitive decline and dementia at the federal, state, local, and tribal levels. This includes Congress reauthorizing the Bold Infrastructure for Alzheimer's Act for another 5 years and providing at least $35 million in fiscal year 2025 funding for CDC to implement the act. Congress should reauthorize the Older Americans Act and provide sufficient funding to enable ACL to incorporate dementia risk reduction education and interventions in relevant Older Americans Act programs. Congress should enhance appropriations of relevant existing federal programs and fund additional new programs that promote cognitive decline and dementia risk reduction. CDC, ACL, CMS, HRSA, SAMHSA, and the Indian Health Service should expand efforts to target resources towards education and outreach of the public health and aging network on dementia risk factors. And existing federal efforts to address health conditions and behaviors that are also risk factors for cognitive decline and dementia should be promoted as beneficial to brain health. In partnership with state, local, and tribal governments, payers, community-based organizations, and relevant private sector entities, the federal government should develop and implement specific strategies to address social determinants of health that affect risk and produce adverse health outcomes related to dementia. Strategies and interventions to address dementia risk factors should include historically underserved communities experiencing the highest prevalence of priority risk factors, low longevity rates, and the highest prevalence of AD/ADRD, with explicit attention to mitigating adverse social determinants of health and strategies and interventions that promote brain healthy behavior. In addition, the CDC's Healthy Brain Initiative Collaborative should develop and disseminate new tools for public health identify opportunities for collaboration, and promote action by state public health, aging, disability, and other relevant agencies that would help address and mitigate dementia risk factors among caregivers. Finally, actions included in the national plan should be aligned with those identified in CDC's Healthy Brain Initiative, State and Local Roadmap for Public Health, and the Roadmap for American Indian and Alaska Native Peoples, forthcoming in 2024, as well as Healthy People 2030 and the Million Hearts Campaign. Recommendation 3, identify and accelerate efforts to reduce risk and intervene early in clinical care. Public payers, health systems, and provider networks should identify and implement a comprehensive set of actions that assess cognitive decline and dementia risk factors, ensuring equitable reach and impact. This will include conducting health risk assessments, identifying opportunities to address possible cognitive decline and dementia risk by known risk factors, identifying existing insurance and health plan benefits related to factors that could potentially help reduce dementia risk, and identifying coverage gaps and inequities that, if addressed, could improve brain health. Educating and training the primary care workforce within the context of the age-friendly health systems framework and dementia-capable communities to address dementia risk reduction and brain health. Finally, increasing identification of persons who have one or more modifiable dementia risk factors to clinically address those factors and potentially mitigate dementia risk. Given the abundance of scientific evidence linking hypertension and brain health, the group recommends that health plans should place a particular emphasis on hypertension prevention and control through a number of activities that are outlined here. I'm not going to go through all of these. HHS should identify and accelerate strategies to improve access to primary care, team-based care, home and community-based care, and preventative care, including better utilization of existing benefits such as Medicare's annual wellness and care planning visits. And Congress should address coverage gaps in Medicare, Medicaid, IHS, and the VA that would improve interventions for identified dementia risk factors, such as expansion of Medicare coverage to include hearing aids and related hearing care rehabilitation services. And we can also give the group an opportunity to add vision services here if they would like. I think that would fall under the purview of small edits. Recommendation 4, initiate and fund research to strengthen the strategies for addressing the potential risk factors for dementia. HHS should utilize fundamental diversity, equity, and inclusion principles while developing, supporting, and monitoring dementia risk reduction research. The federal government should increase scientific research to understand the causal pathways for dementia, to identify and understand the social determinants of health that may elevate the risk of developing dementia or act as barriers to addressing these modifiable risk factors, examine less understood areas of potential risk, identify modifiable factors that may decrease dementia risk and factors related to comorbidities that may aggravate or mitigate dementia risk among those with IDD, identify what modifiable risk factors and lifestyle interventions may slow disease progression and or help maximize functioning among people living with dementia, and identify trajectories of decline in high-risk populations to determine when to target mitigation and prevention strategies and interventions. In addition, the federal government should support translational research that evaluates efforts and identifies key barriers to implement uptake of evidence on risk factor reduction in clinical practice. Develop, implement, and evaluate models of care to increase the uptake of evidence on risk reduction in primary and ambulatory care. And develop, implement, and evaluate models to align public health and healthcare interventions to reduce population risk. Congress should provide sufficient funding for, and relevant agencies within HHS should undertake implementation science on successful clinical trials to develop community-based public health interventions for dementia risk reduction, and research on interventions that would mitigate exposure to possible risk factors for cognitive decline and dementia. The federal government should monitor the outcomes and implications of COVID-19 post-recovery with respect to the risk for cognitive decline and dementia, including long COVID. Particular attention should be paid to the psychological and behavioral issues, as well as potential mediating factors. Recommendation 5, appropriate non-federal government entities, Appropriate, not appropriate, appropriate non-federal government entities and private sector organizations should work to improve brain health. State health departments, state developmental disabilities authorities, and state agencies and tribal authorities tasked with aging and mental health should undertake cooperative efforts to address dementia risk factors. Foundations and charitable organizations that promote healthy outcomes should invest in projects and initiatives in support of brain health, including through training the deployment of community health workers and community pharmacists. And medical associations and health systems should promote physical health to address brain health. Employers should undertake efforts to reduce the impact of hypertension as a strategy to improve both physical and brain health. These efforts should include promoting healthy lifestyles, hosting blood pressure screenings, educating the workforce about hypertension prevention, control, and management, including access to hypertension prevention and control services in employee health benefit plans, and coverage of validated blood pressure monitors at reasonable or no out-of-pocket costs. National, state, and local and community-based provider organizations working with populations at greatest risk of dementia should undertake efforts to improve brain health. And community organizations should facilitate local efforts to improve brain health in their communities. Recommendation 6, establish a set of dementia risk reduction policies at the federal, state, and local levels that will address risk factors, including the social determinants of health for cognitive decline and dementia. Federal, state, and local government agencies should implement policies and systems changes that would improve food availability and quality, including with respect to ultra-processed foods, trans fats, and high-sodium foods, increase access to safe and inexpensive opportunities to engage in physical activity, decrease access to commercial tobacco products, improve the ability of individuals to control and normalize blood pressure, expand hearing testing and use of hearing aids, and increase access to preventative health care and mental health services. National public health organizations, aging services organizations, nonprofits, and medical associations should collaborate on creating and advancing a policy agenda to include access to healthy foods, safe spaces to exercise, hearing aids, means of controlling blood pressure, and preventative and mental health care. And that's it. Okay. I'll take a break from speaking. Okay. I mean, it is the chair. As a reminder, our non-federal colleagues vote on the recommendations. The federal colleagues abstain.
So those of us who are non-federal on the phone and those of us in the room are the ones who will be doing the voting. And this is the voting. We can do it as a group. We had 4 different subcommittees: the clinical subcommittee, long-term services support, risk reduction, and research. So I'm going to go around and ask those who are in the room who are non-federal for their vote. My first vote is yes.
I agree to all the recommendations. There we go. Just to reiterate, I agree to all the recommendations put forth.
This is Randy Bateman. I vote for approval of all 4 recommendations.
Now we'll switch to the phone. Let's see. Susan?
I approve of the recommendations presented. Thank you.
Great. Rhonda?
I too approve of all the recommendations presented. Thank you.
Ken?
This is Ken, and I approve of all 4 recommendations.
Great. And Brother John Richard?
This is Brother John Richard, and I approve of all 4 recommendations.
Thank you. That should be all of our non-federal members. But we couldn't do it without our federal members. We really appreciate all of your support. And so with those adoptions there, we are in time for a break. And we're going to take a break for 15 minutes, which will take us to 3:50.
Thank you, everyone. Also, can we get a round of applause for our subcommittee chairs, because they do a lot of work and they have a lot of meetings and they work on a lot of documents, and so I really appreciate the work that you do, and the recommendations are the result of all of the time and effort that you all put into these, and it's quite a lot. It's a thick document with lots of thinking and work in there, so thank you for all the work that you guys do.
produced by the U.S. Department of Health and Human Services.